All right, let's get right into it. We're going to do an exam-focused, consultant-level deep dive on one of the most notorious injuries in all of orthopedics, the lisfranc fracture dislocation. So get ready, this is the high-yield stuff you absolutely need to nail. And right off the bat, here's why this is so important. Up to 1 in 5, 20% of these injuries are completely missed when the patient first comes in. It gets brushed off as a simple mid-foot sprain, a diagnosis that should always set off alarm bells in your head. And the fallout from missing this, it's a disaster. We're talking about a future of debilitating chronic pain, the literal collapse of the foot's arch, and a major loss of function. This is an injury that can genuinely change someone's life, even their ability to do their job.
Okay, so to really understand this injury, you have to start with the anatomy. Let's break down the architecture of the midfoot, which is actually the source of both its incredible strength and its critical weakness.
So what are we even talking about when we say the lisfranc joint? Well, it's not really one single joint. It's a whole complex. The tarso-metatarsal, or TMT joints. This is that crucial junction connecting the midfoot to the forefoot, and it's all held together by this really intricate web of ligaments.
Now this is the really elegant part of the design. You can see here how the bases of the metatarsals form what's known as a Roman arch, an incredibly stable structure. See how the second metatarsal is recessed, kind of wedged between the cuneiforms? That's the keystone, and just like in architecture, if you pull that keystone out, the entire arch just collapses.
Functionally, it's useful to think of the foot in 3 columns. The medial and middle columns, they're rigid. They provide this stable platform for you to push off when you're walking. The lateral column, on the other hand, has a bit more give, a bit more mobility. That's what lets your foot adapt to uneven ground. Understanding this is key to figuring out the injury patterns.
So, you've got a patient with midfoot pain. How do you unmask this often tricky injury? Well, it all starts with having a really high index of suspicion and knowing exactly which red flags to look for.
In your history, you need to be thinking about 2 main mechanisms. It could be a high-energy crush, but it can also be something much more subtle, like a low-energy twist on a pointed foot. Super common in sports. When you examine them, you're looking for swelling and tenderness right over those TMT joints. But here's the absolute money shot. You have to look at the sole of the foot. That bruising on the bottom, plantar ecchymosis, also called the Ross sign, is practically a dead giveaway for a lisfranc injury.
Okay, so you're suspicious. Your clinical exam is pointing you in the right direction. Now you need to prove it. Let's talk about the imaging that's going to seal the deal.
This is it. This is the critical, non-negotiable takeaway. If you only remember one thing about investigating these injuries, let it be this. You must get weight-bearing radiographs. I can't stress this enough. The non-weight-bearing films can look totally, deceptively normal, especially if it's a purely ligamentous injury.
And this slide just illustrates the point perfectly. Look at the image on the left. That's the non-weight-bearing view. Looks pretty much fine, right? You might miss that. But now look what happens when the patient actually stands on that foot. Boom! The image on the right shows this massive, obvious gap, a diastasis, between the first and second metatarsals. The instability is completely unmasked by putting the body's weight on it.
Another huge sign to look for is the flex sign. It's this tiny little chip of bone you can see right between the first and second metatarsal bases. Now, it might look like nothing, just an insignificant little fleck. But what that actually is an avulsion fracture. The super strong lisfranc ligament has literally ripped a piece of bone off. Finding this tells you you're dealing with a major, unstable injury.
Okay, you've nailed the diagnosis. Now comes the hard part. How do you actually manage it? Well, the entire treatment algorithm hinges on one single central question.
This is it. This is the whole game. Everything you do next flows from this one decision point. Is the joint stable or is it unstable? And your weight-bearing x-rays are what give you the answer.
So if, and this is a big if the injury is genuinely stable and perfectly aligned on those weight-bearing views, then and only then can you think about non-operative management. We're talking about a period of non-weight-bearing in a cast, followed by a very gradual return to activity, usually with some good arch supports.
And let me be absolutely crystal clear on this, because this is a critical safety issue. If there is any displacement, any instability at all, there is simply no role for non-operative treatment. The goal is a perfect anatomic reduction, and that means surgery. End of story.
Now, for those unstable injuries that need an operation, we step into the great debate, ORIF versus primary arthrodesis. Open reduction internal fixation, or ORIF, tries to restore the normal anatomy and save motion.
but it often means a second surgery to take the hardware out and carries a higher risk of arthritis down the line. On the other hand, a primary fusion sacrifices that motion from the get-go, but it creates a stable, painless foot. This is often the better choice when the joints are completely shattered or for certain types of patients.
Of course, no Viva discussion is complete without talking about the evidence, the potential complications, and the long-term outcomes. And with these injuries, the potential consequences are really significant.
In the immediate aftermath, the one thing that should keep you up at night is compartment syndrome of the foot. Especially with those high-energy crush injuries, it's a true limb-threatening emergency. Then, long-term, the most common problem by far is post-traumatic arthritis, even if you did a picture-perfect surgery. And that arthritis is what leads back to the chronic pain and arch collapse we talked about at the very beginning.
And this number really brings home the real-world impact. The functional problems can be so severe that up to 30% of patients, that's almost 1 in 3, may actually have to change their job after a major lisfranc injury. It just highlights why getting this right from the very start is so incredibly important. Okay, let's bring it all home. This is your rapid-fire summary for exam day. These are the pearls you need to have in your back pocket and the common pitfalls you absolutely have to avoid.
These are your buzzwords. You want to be confidently talking about the Roman arch and the keystone concept. You need to mention plantar ecchymosis and the flex sign in your assessment. You have to emphasize the absolute necessity of weight-bearing radiographs, and the goal of your treatment is always anatomic reduction. Use these phrases, and you'll sound like you know exactly what you're doing.
And here are the traps people fall into. Number 1, missing the injury because they didn't get those weight-bearing views. Number 2, writing it off as a simple sprain. And number 3 is a bit more nuanced. Don't get bogged down in classification systems like Hardcastle. They're useful for describing an injury pattern, but they don't really guide your treatment or predict the outcome. The decision to operate is based on stability, not the classification type.
And we'll finish with one last question to really get you thinking at that consultant level. You've done the surgery, you get the post-op x-ray. How do you know you've won? What are the specific radiographic signs you're looking for that tell you, yes, you've achieved a stable anatomic reduction? Think about the alignment of the metatarsals with the cuneiforms. Think about the spaces between the bones. That's the key to a good result.